What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about angina, myocardial infarction, the different types of shock, such as cardiogenic shock, hypovolemic shock, septic shock, neurogenic shock, anaphylactic shock, and obstructive shock. We talked about cardiac physiology and the pressure-volume loops. We discussed rheumatic fever and infective endocarditis, cyanotic congenital heart diseases, and acyanotic congenital heart diseases, acute fibrinous pericarditis and constrictive pericarditis, pericardial effusion and cardiac tamponade, dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. We talked about many cardiac arrhythmias, and then we started talking about the valvular heart diseases. The last video was on aortic valve stenosis. Today we shall talk about aortic valve insufficiency or aortic valve regurgitation, where my aortic valve fails to close. Click the like button, click the subscribe button before my head starts bobbing. This is my cardiology playlist. It has cardiac anatomy, cardiac physiology, cardiac pharmacology, and cardiac pathology. Now get a piece of paper and doodle with medicosis. This is your left ventricle. We start with the left ventricular wall and the left ventricular cavity, followed by the left ventricular outflow tract, and then you find the aortic valve, which has 3 cusps, by the way, and then the aorta itself. And the aorta has many parts. There is the ascending aorta, the aortic arch, and the descending thoracic aorta. The ascending aorta will give us the right coronary artery and the left coronary artery to supply the heart itself. Then the aortic arch will give us 3 famous branches. You need to know their names in order. If I ever show up to your hospital bleeding through my open wounds, I'm going to ask you one question before I let you touch me. Dear doctor, what are the branches of the aortic arch? If I do not get my answer in 3 seconds, I will decline treatment. I would rather succumb to my own wounds than be treated by a doofus who does not know the branches of the aortic arch. The branches of the aortic arch in order are the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. Brachiocephalic, left common carotid, left subclavian. Brachiocephalic, left common carotid, left subclavian. Why do we call the brachiocephalic brachiocephalic? Brachium is the arm, cephalo is the head. Oh, so we'll branch into 2 arteries. One will go to the arm, that's the subclavian artery, which will then become the axillary artery, which will then become the brachial artery. And the second branch is the common carotid artery, which is subdivided into external carotid artery and internal carotid artery. External carotid for the face, internal carotid for the brain. But on the left, they are separated from the beginning. There is the left common carotid, which will give us left external carotid and left internal carotid, and the left subclavian. If you wish to see more videos like this in the future, drop a heart emoji in the comments. Here's the brachiocephalic artery. It subdivides into right subclavian and right common carotid. Then the right common carotid will become right external carotid artery and right internal carotid artery. If you want more medicosis anatomy in your life, check out my anatomy playlist here on YouTube. I have several review videos in every branch of anatomy you can imagine, such as anatomy of the head and neck, upper extremities, lower extremities, anatomy of the thorax, the abdomen, the pelvis and perineum, even neuroanatomy and embryology. Each one of these topics is covered in 3 videos. For example, Part 1 Anatomy of the Thorax is called Quick Review, Part 2 Anatomy of the Thorax is called Ultimate Review, and Part 3 is Clinically Oriented Anatomy of the Thorax, and we repeat the same scenario with each branch. All of this is in my anatomy playlist. Back to the aortic valve. Here's the aortic valve right here. What does aortic insufficiency or aortic regurgitation means? It means that when the aortic valve was supposed to close, it failed to close. Oh, normally the aortic valve should close during diastole, when the ventricle is relaxing to receive the blood from the atrium. You want the ventricle to receive blood from the atrium only and not from the aorta. So you better close the aortic valve. But what if I couldn't close the aortic valve? Then the blood will return to the left ventricle from 2 sources. Source number 1, which is normal, the left atrium. Source number 2, which is abnormal, is the aorta itself. Now put yourself in the position of the poor left ventricle. There is blood coming from here and from here. This is more blood than normal. So this is increased left ventricular and diastolic volume, which is the volume in the left ventricle at the end of diastole. It is higher than normal. According to Frank Starling law, when you increase the preload, the left ventricle will respond by increasing the force of contraction or contractility. So the left ventricle contracts harder with more vengeance, raising the systolic blood pressure, which is the pressure of the blood in big arteries during systole. How about the diastolic blood pressure? Be careful. During diastole, there was supposed to be a pressure of blood in the big arteries. This was supposed to be 80 diastolic and 120 systolic. But in aortic regurgitation, the 120 is going to be higher than this. Let's make it 150. As for the diastolic, let's think about it. What's the definition again? It's the blood pressure in big arteries during diastole. Big arteries like the aorta, yeah, but during diastole, because of the aortic insufficiency, the blood is returning to the left ventricle, leaving less blood in the aorta during diastole, lowering the diastolic blood pressure. Let's call it 60 instead of 80. Now, what was the original pulse pressure in normal circumstances? 120 systolic minus 80 diastolic equals 40 pulse pressure. 40 what? Millimeters of mercury, of course. But in aortic regurgitation, the systolic is 150 millimeters of mercury, the diastolic is 60 millimeters of mercury, so what's the new pulse pressure now? 150 minus 60 equals 90 millimeters of mercury. So what happened to the pulse pressure in aortic regurgitation? Widened pulse pressure. 90 is wider or higher than 40. It is this widened pulse pressure that explains many of the signs of aortic regurgitation, as we will discuss soon. Remember the four heart valves. Mitral valve is between left atrium and left ventricle. Tricuspid valve is between right atrium and right ventricle. The aortic valve is between the left atrium and the aorta. The pulmonic valve is between the right ventricle and the pulmonary trunk. Each one of these four valves can suffer from two separate diseases, stenosis or regurgitation. Stenosis is a narrow valve. It was supposed to be wide open like this, but it failed to be wide open. It is narrow. This is stenosis, difficulty at opening. Regurgitation is difficulty at closing. So we have aortic stenosis, aortic regurg, mitral stenosis, mitral regurg, pulmonic stenosis, pulmonic regurg, tricuspid stenosis, and tricuspid regurg. Let's talk about aortic stenosis, difficulty at opening. But when was the aortic valve supposed to open in the first place? Is it during systole or during diastole? The answer is during systole, and that's why aortic stenosis is a systolic murmur. How about aortic regurgitation? Difficulty at closing. But when was the aortic valve supposed to close? During the diastole of the ventricle, and that's why aortic regurgitation is a diastolic murmur. How about mitral stenosis? When was the mitral valve supposed to open? During diastole, and that's why mitral stenosis is a diastolic murmur. How about mitral regurgitation? Difficulty at closing. But when was the mitral valve supposed to close? The answer is during systole of the ventricle, so therefore mitral regurg is a systolic murmur. Then the pulmonic is just like the aortic because they are in the same position. So therefore, pulmonic stenosis, just like aortic stenosis, is going to be systolic. And pulmonic regurg, just like aortic regurg, will be diastolic murmur. Tricuspid is similar to the mitral. Both are atrioventricular valves. So if mitral stenosis was diastolic, then tricuspid stenosis is diastolic. If mitral regurg was systolic, then tricuspid regurg is also systolic. You can look at it in a different way. The aortic is similar to the pulmonic, and the mitral is similar to the tricuspid. Or you can say that the aortic is opposite to the mitral. So if aortic stenosis is systolic, then we can say conversely, mitral stenosis has to be diastolic. If aortic regurg was diastolic, then it follows logically that mitral regurg is going to be systolic. And you can play the same game between pulmonic and tricuspid. They are opposites. If pulmonic stenosis is systolic, tricuspid stenosis is diastolic. But how can we remember all of this? Well, the only thing that you need to memorize is this inappropriate word, ASS. ASS, what does that mean? It means that aortic stenosis is a systolic murmur. Okay, And then, if you decide to change one of these two letters, you have to change systolic into diastolic. For example, when I change the A into the M, this becomes mitral stenosis right now, and mitral stenosis is a diastolic murmur instead of systolic. Because when you change one letter, you gotta change systolic into diastolic and vice versa. Now look what's gonna happen when I change aortic stenosis into aortic regurg. How many letters did change? The answer is just one. We changed the stenosis into regurgitation. So therefore, you gotta flip the systole into diastole. It's like rotating 180 degrees. Up becomes down, down becomes up, right becomes left, left becomes right. But what if I change both letters? The aortic becomes mitral, and the stenosis becomes regurg. Now you gotta flip it twice. Systolic becomes diastolic. That's one flip. Flip it again, diastolic becomes systolic. So we are back at square one. So, if you flip one letter, change systole into diastole or diastole into systole. If you change both letters, keep it as it is. Just like rotating 360 degrees. Your destination is exactly the same as your origin. And then, of course, since the aortic valve is similar to the pulmonic valve because they are at the same levels, these are the semi-lunar valves. So if aortic stenosis is systolic, that's the only word I memorize. Therefore, pulmonic stenosis is also systolic. Mitral stenosis is diastolic, so tricuspid stenosis is diastolic because the tricuspid is equivalent to the mitral. Aortic regurg is diastolic, pulmonic regurg is diastolic, mitral regurg is systolic, so therefore tricuspid regurg is systolic as well. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. So let's play this game again. They're asking me about mitral regurg. Is it systolic or diastolic? Well, I only memorize one word, which is that aortic stenosis is systolic. How many letters did I change from aortic stenosis to mitral regurg? I flipped both of them, which means you keep systolic the same. Let's try this one. How about tricuspid regurg? Tricuspid is equivalent to mitral, so mitral regurg is systolic, therefore tricuspid regurg is also systolic. Let's try mitral stenosis. Well, aortic stenosis is systolic. How many letters did I change? I only changed one letter. The A became M. So therefore, I changed systole into diastole, and therefore mitral stenosis is diastolic. You can do it this way by memorizing one word and then flipping 180 degrees versus 360 degrees. Or you can just understand it. When we say mitral stenosis, narrowing of the mitral valve, difficulty at opening. But when is the mitral valve supposed to open? Is it supposed to open during systole of the ventricle or diastole of the ventricle? Well, the mitral valve should open during ventricular diastole to allow the blood to move from the atrium to the ventricle. So therefore, the mitral valve should open during diastole. And mitral stenosis is difficulty at opening, ergo mitral stenosis is a diastolic murmur. This is the left ventricular wall, this is the left ventricular cavity, this is the left ventricular outflow tract, this is the aortic valve about here, and then the aorta after that. Aortic regurgitation, which is today's topic, is failure to close. It did not close when it should, therefore during diastole, blood will return from the aorta to the left ventricle, and that's why aortic regurg is a diastolic murmur. More blood is returning to the left ventricle, more blood returns to the left ventricle. Is this volume overload or pressure overload? This is volume overload. There is too much volume returning to the left ventricle, because remember, there is volume returning from the left atrium and volume returning from the aorta at the same time. This creates volume overload. So what? Volume overload, which is the same thing as increased preload, can lead to eccentric hypertrophy to the ventricle. Since we're talking about aortic valve today, this is the left ventricle. Left ventricular hypertrophy or enlargement. What kind of hypertrophy? Is it concentric or eccentric? The answer is eccentric, because the cavity is getting wider rather than the muscles becoming thicker. This is the normal left ventricle. This is the eccentric hypertrophy. This is concentric hypertrophy. In the last video, we talked about aortic stenosis. It caused pressure overload, raising the afterload, and the ventricle develops left ventricular hypertrophy in chronic cases. But in aortic regurg, thanks to the volume overload or increased preload, with chronicity, the left ventricle can develop eccentric hypertrophy. This is not peculiar to aortic regurg, but any regurgitating murmur, such as mitral regurg, tricuspid regurg, or pulmonic regurg. If it's aortic regurg or mitral regurg, we expect the eccentric hypertrophy in the left ventricle. But with pulmonic regurg and tricuspid regurg, we expect the eccentric hypertrophy in the right ventricle. With the eccentric hypertrophy and the volume overload, expect S3 gallop or S3 heart sound. Remember, if S1 is here and S2 is there, these are the normal heart sounds, the lub and the dub. S3 happens after S2, whereas S4 happens before S1. If I have S3 gallop, then we will hear it like this, lub dub dub, just like pronouncing Kentucky, Kentucky, lub da dub, lub da dub, lub da dub. But if I have an S4 gallop, then we hear it like this, la lub dub, la lub dub, la lub dub, or Tennessee, Tennessee, Tennessee. So S4 is Tennessee, whereas S3 is Kentucky. In eccentric hypertrophy, the sarcomeres are added in series. That's how you end up with longer muscles. But in concentric, the sarcomeres are added in parallel, so you end up with thicker muscles. Eccentric hypertrophy. Look at this humongous cavity. This heart is very good at diastole, but bad at systole. Aortic regurgitation stages. There is stage A, B, C, and guess what? D. In stage A, I'm just at risk of aortic insufficiency. Stage B, progressive aortic insufficiency. Stage C, asymptomatic severe aortic insufficiency. And in stage D, there is symptomatic severe aortic insufficiency. This classification affects the protocols of management of aortic regurgitation. Here is S1, here is S2. Between S1 and S2, this is systole. Between S2 and the following S1, this is diastole. Normally, diastole is longer in duration compared to systole. As we said, aortic regurgitation is a diastolic murmur. How does it look like? It's a diastolic decrescendo. Decrescendo means what? It starts high and then decreases like this. And it usually covers or masks S2 or the dub. So instead of hearing lub dub, lub dub, lub dub as usual, you're gonna hear lub dish, lub dish, lub dish. And in which area do we hear this aortic regurgitation murmur? It's not in the first aortic area, because that's for aortic stenosis. Instead, we hear the murmur of aortic regurgitation in the second aortic area, which is in the left third intercostal space. Here's the first intercostal space, second intercostal space. This is the third intercostal space. How do you find the third intercostal space? Easy. You go to this manubriosternal junction. You can palpate an elevation in this area. Right next to it is the second rib. Go beneath it, second intercostal space. Beneath it, third rib, beneath it. That's the third left intercostal space. Just close to the sternal border, you're going to hear the murmur of aortic regurg, which is diastolic decrescendo murmur. S1 is here, S2 is there. Between S1 and S2, this is systole. Between S2 and the next S1, this is diastole. As you see, aortic regurg is a diastolic decrescendo murmur. It is a high-pitched murmur. It is a blowing murmur. And it's early diastolic. It starts from the beginning of the dub. Unlike the murmur of mitral stenosis, which does not start early in diastole. Please recall that in aortic regurgitation, we expect increased systolic blood pressure, decreased diastolic blood pressure, and a widened pulse pressure, which is the difference between the systolic pressure and the diastolic pressure. The preload on the left ventricle increases. This is increased left ventricular and diastolic volume. The effect of aortic regurgitation on the pressure-volume loops. Here is the normal pressure-volume loop. Pressure on the y-axis, volume on the x-axis. To learn more about the pressure-volume loops, please refer to my physiology videos in this cardiology playlist. This higher volume right here is the end diastolic volume, which is the volume in the left ventricle at the end of diastole. And this lesser volume right here is the end systolic volume, which is the volume in the left ventricle at the end of systole. Between the end systolic volume and the end diastolic volume, what do we have? Well, EDV minus ESV equals what? This is your stroke volume. So the distance from here to here is the stroke volume. All of this is normal. What's going to happen if I have aortic regurg? I want you to look at the end diastolic volume. Oh, it has been shifted to the right. This is the new end diastolic volume, which is higher than normal. So there is increased left ventricular end diastolic volume. How about the end systolic volume? it did not change much. It maybe increased a little because the poor left ventricle cannot keep up with the increased supply of blood received during diastole from both the left atrium and the aorta. What do you think happened to the stroke volume, which is the distance or the volume from here to here? EDV minus ESV. Of course, this new stroke volume is bigger than the normal stroke volume. So the stroke volume increased, and this is explained by the Frank-Starling law. If you give me more blood, I will contract more and give you more volume. The greater the input, the greater the output. Next, the graph that has the blood pressure on the y-axis and time on the horizontal axis. Normally, the pressure in the aorta, the red color, during systole is 120 millimeters of mercury, but the pressure of the aorta during diastole is 80 millimeters of mercury. However, when it comes to the left ventricular pressure, during systole, it goes up to 120 millimeters of mercury, but during diastole, it decreases to almost zero. Why is the aorta different from the left ventricle? Was explained clearly in my physiology videos in this cardiology playlist. All of this was normal. However, what do you think is going to happen in aortic regurgitation? There is widened pulse pressure, which is the difference between systolic and diastolic. Here, in normal situations, what's the pulse pressure? It is the systolic blood pressure of 120 minus the diastolic of 80 to give me a pulse pressure of 40 millimeters of mercury. But look what happened here in aortic regurgitation. We have higher systolic and lower diastolic, widening the pulse pressure between the two, and this fact is very important. Aortic regurgitation has a widened pulse pressure. So what if the aortic regurgitation has a widened pulse pressure? This explains all the following: the Corrigan pulse, the Musset sign, the Traube sign, Quincke sign, Duroziez sign, Hill sign, Mueller sign, Becker sign, Mayne sign, Rosenbach sign, and Gerhard sign. But let's not get ahead of ourselves. Aortic regurgitation, the history. The causes. The most common cause in developing countries is rheumatic fever. The most common cause in developed countries are all of the following, including aortic root dilation. And this is a very important thing to remember. When you have a dilated root or ring of the valve, it went from looking like this to the valve looking like this. It is very hard for this dilated valve to close. Failure to close is called regurgitation or insufficiency. Bicuspid aortic valve. Normally, the aortic valve has 3 cusps. But here, in this abnormal condition, I am born with 2 cusps only, making it harder for the valve to close, which can lead to aortic regurgitation. Keep in mind that in the last video, when we talked about aortic stenosis, bicuspid aortic valve was also a risk factor. So bicuspid aortic valve can contribute to aortic stenosis and or aortic regurg, or both, named double aortic. Dystrophic calcification or fibrosis of the aortic valve can lead to aortic regurgitation. Infective endocarditis can ruin any valve, and the aortic valve is no exception. Symptoms. The patient complains of shortness of breath upon exertion, presyncope, syncope, chest pain, termed angina, congestive heart failure, low cardiac output symptoms. Because after a while, the poor left ventricle will undergo eccentric hypertrophy from the volume overload. Eccentric hypertrophy makes the ventricle good at diastole but poor at systole. Because it's poor at systole, we can suffer from symptoms of low cardiac output, including dizziness, headache, and syncope, because there is less blood reaching the brain, ischemic heart disease, because there is less blood reaching the heart itself through the coronary arteries. The kidney might suffer oliguria, the skin might be cold with peripheral cyanosis, and the skeletal muscles might develop fatigue. Because it's a volume overload, expect S3 gallop rhythm. Due to the enlargement of the left ventricle, it enlarges outwards like this, which causes displacement of the point of maximum impulse from here to here. The murmur of aortic regurg is a diastolic decrescendo murmur at the left third intercostal space. Now, what is Austin-Flint murmur? Austin-Flint murmur is a murmur that is very similar to mitral stenosis murmur, i.e., it is low-pitched, it is diastolic rumble, and it's better heard at the apex of the heart, just like mitral stenosis. Now, why would we have a murmur that mimics mitral stenosis in a patient who has aortic regurgitation? Well, in reality, no one knows. Many hypotheses tried to explain this. Some of them included the fact that the mitral valve is closer in anatomical location to the aortic valve. Others argue that it's related to the velocity of flow. There is higher velocity of blood flow across the mitral valve thanks to the aortic regurgitation, and this rapid jet of blood keeps the anterior mitral leaflet in a relatively closed position, obstructive the diastolic filling of the left ventricle, giving us the murmur that mimics mitral stenosis, and this is called the Austin-Flint murmur. Because of the widened pulse pressure, we expect all of the following. What is Corrigan pulse? Corrigan pulse is the same as water hammer pulse, or collapsing pulse, or bounding pulse. Where can we feel it? We can feel it in the wrist over the radial artery, or in the groin area over the femoral artery. Because of the big difference between systolic pressure and diastolic pressure, we can feel this water hammer pulse. Next, du Musset sign. According to legend, the famous French poet Alfred de Musset used to sit in the Parisian salons, bobbing his head all day long, bobbing his head back and forth, back and forth, back and forth. People said, oh, he's just a poet. And that's what crazy poets do. What they did not know, that he was bobbing his head because of aortic regurgitation. This is a symptom of aortic regurgitation. Why would I bob my head back and forth? Because of the big difference between systolic blood pressure and diastolic blood pressure. My head bobs with each heartbeat. Next, the pistol shot femorals, which is Traube sign. This is a loud sound over the femoral artery with systole and diastole. Next, look at the base of the nail bed or the lips of the patient and you will find the capillaries pulsating. This is a sign of aortic regurgitation. Next, put your stethoscope on the femoral artery. You'll hear back and forth, to and from, intermittent femoral murmur. Next, go and measure the brachial systolic blood pressure and then measure the popliteal systolic blood pressure. You'll find that the popliteal systolic blood pressure is greater than 20 millimeters of mercury higher than the brachial systolic pressure. This is Hill sign. But if the difference is greater than 60 millimeters of mercury, then this is called severe aortic regurgitation. Next, ask your patient to open his or her mouth and then look at the uvula. The uvula is pulsating with each heartbeat, and this is aortic regurgitation. Next, get an ophthalmoscope or a fundoscope and look deep into your patient's eye. You'll find visible pulsations of the retinal arteries. This is Becker sign. Or visible pulsations of the pupils. The pupils of the eye are dilating and constricting, dilating and constricting, dilating and constricting. Next, measure the blood pressure in the patient's brachial artery as usual. And then raise the patient's arm up and re-measure the blood pressure. If there is a decrease or a drop in the diastolic blood pressure of greater than 15 millimeters of mercury, this is a sign of aortic regurg. Next, palpate the liver carefully and gently. You might feel systolic pulsations of the liver, a sign of aortic regurg. Palpate the spleen. If you find systolic pulsations of the spleen, this could be aortic regurg. But of course, if you want accuracy, we need echocardiography, such as the transthoracic echo or the transesophageal echo. If we do EKG, we might find the findings of left ventricular enlargement. In the vast majority of cases, the EKG cannot tell you the difference between concentric hypertrophy and eccentric hypertrophy, but it will tell you that the left ventricle is larger. If we do a chest X-ray, you might find the left ventricular enlargement, aortic root dilation, and pulmonary edema. Why pulmonary edema? Because the blood is returning from the aorta to the left ventricle, and there is blood returning from the left atrium to the left ventricle. Eventually, the left ventricle will get overwhelmed. Blood will accumulate in the left ventricle, then in the left atrium, then in the pulmonary veins, then in the lungs, causing pulmonary edema and sometimes even pleural effusion. What if the echocardiography is equivocal and inconclusive? Do a cardiac catheterization. This will tell you the status of the aortic valve, the degree of the left ventricular dysfunction, and much more. How can we manage aortic regurgitation? We start with non-pharmacological management. Reduce sodium intake. Decrease participation in competitive sports. If there is endocarditis, or if the aortic regurgitation is severe enough, we should do prophylaxis for the infectious endocarditis. Next, pharmacological management. ACE inhibitors. Why? Because they reduce the afterload. We can try vasodilators like nitroprusside in acute aortic regurgitation. And if there is pulmonary edema, give diuretics. Here's a question for the A++ students. What's the effect of beta blockers on the preload? The answer is beta blockers increase the preload. They raise the preload. And this poor heart already has volume overload. That's why there is an S3. So therefore, do not give beta blockers because they prolong diastole and they boost the preload, which is gonna overwhelm the poor left ventricle even more. In acute aortic regurgitation, intra-aortic balloon pump is contraindicated. Next, surgical referral. Who needs referral to surgery? Patients with acute severe aortic regurgitation, for example, after infectious endocarditis. Patients with cardiogenic shock. Patients who have symptoms and have severe aortic regurgitation, regardless of the status of left ventricular function. Patients who are hemodynamically stable, have severe aortic regurgitation, and undergoing surgical procedures such as coronary artery bypass graft or surgery on the aorta. Next, patients who have evidence of systolic dysfunction, meaning that the ejection fraction is less than 50%. They require surgical referral. And patients with evidence on echo of severe, significant enlargement of the left ventricle require surgical referral. Okay, what is the surgeon going to do? You can replace the aortic valve and you can put an intra-aortic balloon pump, but you only do this for chronic aortic regurg, not in acute regurgitation. Let's review. Aortic regurgitation is characterized by widened pulse pressure leading to bounding pulses. It is written with a B, not a P, but let's keep it simple, just for the mnemonic to work. Diagnosis, echo is the best. Medical treatment, reduce preload by restricting sodium intake and giving diuretics such as loop diuretics, especially if there is pulmonary edema. When should we perform surgery? If the left ventricular ejection fraction is less than 55%, other authors say 50%, or when the left ventricular end systolic diameter is greater than 55 or 50 millimeters, or when the left ventricular end diastolic dimension is greater than 65 millimeters. Do you want to learn about angina, myocardial infarction, strokes, cardiac arrhythmias, ARDS, acute limb ischemia, and the toxidromes? Download my emergency medicine high yields course at medicosisperfectionalis.com. To learn about the antiarrhythmics, antihypertensives, antihyperlipidemics, anti-anginal medications, diuretics, and digoxin, download my cardiac pharmacology course. And to learn about cardiothoracic surgery, vascular surgery, neurosurgery, orthopedic surgery, trauma surgery, general surgery, and more, download my surgery high yields course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.